Public health care is largely seen as sacrosanct in this country. It's also grappling with multiple crises simultaneously, some due to the pandemic, some dating back before that. This week, Ontario announced it would allow more private delivery, which it said would tackle wait lists for some of the tens of thousands of surgeries delayed due to COVID. Reaction to that announcement is mixed. Let's find out why with Dr. Rose Zacharias, president of the Ontario Medical Association, Natalie Mara, executive director at the Ontario Health Coalition, and Martin Redcon, political columnist at the Toronto Star. Welcome to all of you in our studios. Now, Ontario has made a major decision, as we said, to expand private delivery of its public health care, rather. According to the three-step plan announced by Health Minister Sylvia Jones on Monday, the province will add 14,000 cataract surgeries through new centres in Windsor, Kitchener, Waterloo, and Ottawa, put $18 million in existing centres across the province for surgical procedures, and then issue more licenses to open more clinics. We're just going to get off the top what your thoughts are. Martin, I'm going to start with you. Do you support this move?
Well, I think I support anything that tries to make things better. And I think we have to remember today that we're already doing a lot of this, and this announcement will just do more of it. So this is not, the Premier did a bit of a Pinocchio nose stretch when he said this was a bold move. It's actually a bit anticlimactic. And I know that some people are apoplectic about it. We can talk about it today. But I think it is an attempt to look at the low-hanging fruit and grab it, which is not a bad thing, but it's not going to save the world either.
All right. Rose?
So wait times have been an issue even before the pandemic, and we are dealing with a surgical backlog. While we dealt with the crisis of COVID, many surgeries and procedures were being shelved. No one's fault, but we have a problem now, and our patients are waiting too long for care. So encouraged by the announcement with the goal of catching up on the backlog and implementing a structure to deal with wait times. Indeed, Ontario's doctors want to be at the table of implementation, adherence to publicly funded principles, a human health resource strategy, as well as assuring that every patient has access to safe and high-quality care.
All right, Natalie.
Yeah, I don't think that this is really about wait times at all. Frankly, this is about privatizing public hospitals, and it is a serious problem. The bottom line is that in virtually every hospital in Ontario, the large hospitals and the small hospitals have operating rooms that are running at under capacity. They have been for years. They'll be closed for weeks or months at a time, or even permanently due to underfunding. So there is all kinds of existing capacity in public hospitals. The government is choosing not to support and resource that capacity, and instead to take our money and rebuild that system in private for-profit clinics. And I would disagree just on the facts about how much of that is done already. No government since Mike Harris has tried to expand the independent health facilities, what are a euphemism for private clinics. And we don't really actually have very many surgical clinics in Ontario.
All right, I'm going to stick with you. I want to talk human resources for a moment here. Will this change help solve the current staffing shortage that we have, whether it's nurse burnout, 2 years of pandemic that we're going through, just in general, people seeming to be leaving this industry, or will it make it worse?
I think it's going to make it worse. I mean, the issue is there's two things that need to be done. One is fast track major recruitment of PSWs, like Quebec did after the first wave. 3-month intensive training like they did, get them out there. That's chronic care hospital beds, long-term care, home care, get them out working. Quebec did it. It's a model that could work. This government has refused to do it so far through the entire pandemic, and we're in a crisis across the board, hospitals, home care, long-term care. For nurses, it takes longer to train them. In the short term, the only way to deal with this crisis is to attract back the retired nurses. We need them in the public hospitals. Like, it doesn't make sense to say, here, we're going to attract back the retirees to do a whole bunch of elective surgeries and leave people who have complicated cancer treatment surgeries not able to get them. It doesn't make any sense. It doesn't make sense to shift the financial resources or the human resources in that kind of skewed way. That's what this would do. No, we need them in the hospitals where they can provide the full range of services that patients need and where triage is based on need.
I do want to add to that, and I'll ask this question, is, the government recently announced that they are hopefully going to introduce new legislation that would allow healthcare workers from other provinces in Canada work quite quickly here in Ontario. Does that change things at all?
I mean, they have shortages too. Like, you know, what we're doing is if we're taking the existing pod, we're just, you know, rejigging an existing pod. I don't see a lot of hope in that. No, we need a big recruitment strategy. We need to change the working conditions so that they can recruit them back, you know, and they need a way to do it. Like if they were serious, we'd see a portal, a ministry portal. They'd have a way to zoom people out of, you know, having just retired, you know, recent retirees back into various hospitals and so on to help. There would be some adjustment to the big complaints around workload, too many patients per staff, you know, around, they would do something about the for-profit staffing agencies that are cannibalizing the workforce and so on. You know, none of that is happening.
Rose, I'm going to come to you in terms of same question to you when we talk about human resourcing. Will this change help solve the staffing shortage that we see right now?
We need a human health resource strategy. Ontario's doctors are concerned about the doctor shortages, the nursing shortages. I've worked in an emergency department for 20 years, and so clinically, I know the value, the critical value of every member of the healthcare team. And I also know what it's like to show up short-staffed and still the medical, legal, compassionate responsibility to provide high-quality, good care to everyone who needs it. And so we need a human health resource strategy. That's why, with a new introduction in Ontario of dealing with the elective surgeries that have been shelved and wanting to bring our patients and get them access to those cataract, hip, and knee surgeries that they've been waiting too long for, we need a human health resource strategy. We need an implementation committee with all the key stakeholders at the table, Ontario's doctors included. You know, I do see this model as being possibly a way to preserve and even retain staff. When you think about a dedicated ambulatory clinic and offloading the hospital ORs, where those same surgeries are at risk of being canceled or postponed because a hospital OR has to deal with anything and everything that comes in. When you think about bringing those elective procedures out, then the idea is that the staff follow the patient. And so it may be that hospitals need less staff because those procedures are being done in a different focused setting where studies show more patients can be seen and costs can be reduced. Measurements boast a better patient experience, a better provider experience, which may indeed bring back some of our early retirees that have left the profession, nurses that have left because of burnout. This may indeed be a model of retaining and recruiting more staff.
All right, Martin, I'm going to come to you. I see your head, you're nodding your head. So
Shaking
I'm gonna come to you for a response there, but I want to move on here for a quick second. Martin, Ford has repeatedly stated that the status quo isn't working, and even went so far as comparing Ontario's healthcare system that to Cuba and North Korea. I think a lot of that has more to do with the country's politics than anything. Is there a fair argument there? Is it really that bad?
I don't think we're part of an axis of evil, if that's what Doug Ford was suggesting. So no, it's not that bad at all. It's pretty good, but it's not fantastic. And there's a myth in Canada that there's this cult of Medicare that we have, it's evolved to the highest level, that we are the model of the world. And we forget, yeah, we're a lot better than the Americans, but we are behind, way behind the rest of the West. Countries with universal public healthcare systems, we spend far more per capita as a percentage of GDP on healthcare than virtually any other country, developed country, with a universal public system such as we have. I said public. I want to just, for the record, give people some context. Forgive me. But because Natalie has said it's a public system and her press releases, which I get, say Canada's public Medicare system. It is a system that is required by law to be universal and publicly accessible. It is not a public delivery system. So you go to the lab for your blood test, you get your x-rays for the minor stuff, like I say minor, when I have a broken ankle or a broken knee, I won't call it minor, but a sprain. It's at a private lab. You know, colonoscopy clinics can be private labs. And so I agree with Rose that taking things out of hospitals is not a bad thing. And so Natalie said that we are effectively cherry picking, that the profiteers will be scooping up the best, juiciest cherries from which they can skim the best profits and leaving the tough stuff for the hospitals. And you're nodding, but that's exactly what the doctors want. That's what the CEOs of all the major hospitals want. They want to parcel out the stuff, the low-hanging fruit that I talked about earlier, because, and I don't want to suggest that these are factory farms, but I think I forget the word you use, but it's something you can systematize it. My words, you can streamline these procedures. Everybody knows now that with cataracts, you can actually make it a lot faster than it used to be. So that's, I'm sorry, I got off on a tangent there, but that's, I think what we need in the debate is context, was my point. And I've forgotten your original question, Jane, I'm sorry.
That's right, it was about whether or not we had a really bad health system in comparison to North Korea and Cuba. But
So I think we're better. I think we're actually better than North Korea and Cuba. You can tell the Premier I said that, but I actually think we're not as good as we think we are, and so we need and I think a lot of patients and a lot of doctors know that. And that's why, and I'll stop in a second, but that's why we had something called hallway medicine. Remember, hallway healthcare? 2018 election was fought on that. It's one of the reasons Doug Ford won and the Liberals lost, because the Liberals gave us hallway healthcare. Actually, a flu surge. A couple of flu surges gave us hallway healthcare. And then a pandemic, who knew that was coming, gave us a lot worse. We had a huge disruption, and that's why people are trying to figure out how to do things a little differently.
I'm going to stick with you just because you brought up the campaign there. It's, you know, Doug Ford was reelected in 2022. I heard about highways. I did not hear about this. Why didn't Ford campaign on this, on his platform?
Probably he was afraid of the reaction.
Well, he did the opposite. In fact, their spokespeople swore up and down they were not going to do this, because we held 20 press conferences warning that they were going to do this after the minister kind of misspoke and said in a press conference that they were going to expand the private hospitals and clinics. And they literally sent a spokesperson out after us, after every press conference, and denied up and down categorically, leading into the election, that they were going to do this. And then 2 months after the election, they moved forward with doing it. I mean, it is profoundly undemocratic. They have no mandate, zero mandate to do it. That's clear.
So to your question, politicians do that all the time. And should every politician be upfront and transparent about what they're going to do? Yeah. But I also think the rest of us who are, as a journalist, you know, I can be ideological about this. I like public ownership. I mean, I wish the post office was still run. I almost wish that, I used to think I wish there weren't postal boutiques in Shoppers Drug Mart, because I always thought that our friends at the Canadian Union of Postal Workers should not lose their jobs. But you know what? Those boutiques in the Shoppers Drug Mart are pretty handy now for getting my parcel from Amazon or whatever. And so I just think we also need, just like politicians should be honest, I think we should have, and just like doctors should be transparent in billing, and the doctors who run these clinics, for profit or not for profit, which also transgress transparency sometimes. Sometimes the hospitals don't tell you about the upselling that people talk about, which is not extra billing. Upselling is not extra, we can talk about that. So I think everyone should be honest in this debate, and not just the politicians.
All right, I'm going to give you some chance to respond to some
I
of
was
the
going to
comments.
say there's so many. There's
a
two
few.
in one
Yes.
here. And so the only sort of voice for the public, you know, side of this is me, and I don't have time to respond to everything that you said.
Think I'm
But
also a voice of the public.
I'll choose a couple of things. One is just talking about where you provide this surgeries and diagnostics, whether it's a focused facility or not, is not what this debate is about. It's about who owns it. It's whether it's under the governance of public hospitals that are owned and operated in the public interest on a not-for-profit basis, or whether it's handed over to the for-profit clinics. There are ambulatory care facilities in Ontario. Those are day hospitals that are operated by the public hospital system with a quality of care regime, the public governance, all of those things that exist for public hospitals. We do not have that for the private clinics. In fact, the private clinics, if you go and look up their inspection reports, good luck to you, they're not available publicly. The ministry purposefully contracted that out to a third-party organization. Why? Because freedom of information legislation covers things, you know, under the ministry, but does not cover the third party. You can find one-liner inspections on some of the out-of-hospital facilities, and that's it. In terms of quality, those colonoscopy clinics that you talked about actually had serious quality colonoscopy problems. They didn't breach the colon. They didn't do the test properly. There were more missed cancers. There are higher death rates in the for-profit clinics and so on. And in addition, they extra bill patients for the medically necessary tests and procedures that they do. The cataract surgery clinics in Ontario are where we see patients routinely being billed $2,000 per eye for the cataract surgeries. The reason we oppose this is not around anything to do with workforce issues or what have you, although they are serious as well. It's because if they hand over, as Doug Ford said, 50% of the hospital surgeries in this province to private for-profit clinics, they'll dismantle the public hospital system, and we will not be able to protect single-tier public Medicare in this province or in this country. It's serious. And so we will fight it. We'll fight it on the public interest in protecting healthcare that is run in the public interest and not for private profit, with all of the add-ons, poor quality, and behaviors that the private sector brings to the practice of healthcare.
I can't tell you how many emails I've received since my columns this week from patients saying that they were extra billed, to use your word, they weren't extra billed, they were upsold, extra billed by a hospital or by a not-for-profit clinic. So we shouldn't conflate and mix up this idea of, quote, extra billing, which is illegal in this country. So anybody who extra bills,
name me one
gets
hospital
prosecuted.
that's charging patients for cataract surgery. No, like, being
not,
totally
not for
honest.
Cataract surgery.
But the private cataract clinics are charging patients
if I
for
may.
cataract surgery. No, I mean, let's talk about apples and apples here, right?
I agree. Let's talk
you
about
may
apples
pay
and
for
apples.
like a cast in a public hospital, but in a private clinic, you're charged for the cataract surgery routinely. In BC, Saskatchewan, Alberta,
Okay, can we
they're
talk about
selling
Ontario?
shoulder surgeries.
Let's talk about Ontario.
All right, let's get.
So you asked about so-called apples to apples. So if you're in a cataract clinic and a surgeon says you can get the basic lens covered by OHIP, or you can get something that allows you to take off your glasses so that you won't have to wear glasses anymore. Apples to apples, you can do the same thing in the hospital and they'll charge you hundreds, if not thousands of dollars for that extra lens. So you can't compare somebody who gets an upgraded surgery and agrees to that in a clinic with somebody who doesn't get it in the hospital.
That's
So
not
apples
what's
to apples.
happening. Like, what you're describing is not.
If I can just finish respectfully, I have emails from patients. So maybe they're lying. Maybe their experience isn't true, but their truth and their experience.
We have surveys of 400
if I
patients.
can, their truth and their experience is that they were upsold and agreed to it and paid for it in a hospital. They're actually not complaining about it. They're just trying to point out that this is already happening. And so apples to apples, if you get the basic lens in a private clinic, you shouldn't be charged extra.
If I can,
and if you
though,
are, and if
Very
you are,
quickly,
then
sorry.
complain. If you are, then complain. That's extra billing.
Right. In the private clinics, what they're actually doing is not telling you that you have a choice around whether or not you get the lens. They attach the lens to the surgery and charge the patient for it. No choice, no clear information, no informed consent. And there's a reason why that has come into the public hospitals in recent years, and it's in the cataract, it's mostly around cataracts. It came from the private clinics and has been expanded. Not all hospitals do that, by the way, only some, and they're not in, you couldn't find me a hospital, I don't think, public hospital in Ontario, where a patient is actually being charged for the cataract surgery.
So just
they
to be clear,
are doing that. They are absolutely doing that in the for-profit clinics.
So quick point
in
here.
Ontario.
Just a quick point. Just to be clear, everything you're saying is happening now, pre-Doug Ford, and has happened ever since.
They haven't stopped it, and now they want us to believe they're going to stop it when they bring in way more.
It happened under the Liberal government. It happened under the NDP government, because you said Mike Harris.
The Liberal government actually cracked down on it.
All right, we're gonna have to wrap. Sorry, we're gonna have to go to Rose.
Yeah.
Unfortunately, sorry,
Yeah.
Martin. Appreciate it, but let's bring you into this conversation. Will this expansion to private delivery, is it a step towards more for-profit healthcare providers, or perhaps even a two-tier health system?
I'm hearing the emotion in the room, and Ontario's doctors are very clear. We want to do right by our patients, and we are for strengthening a public healthcare system. In the system already is private delivery. Doctors are small business owners in the community. Family doctors are responsible for their overhead. They pay their staff. So this model of care, which we see many benefits to, if implemented well, would be seeing the patients that are currently waiting to be seen. I've, as president at the Ontario Medical Association, have spoken with my physician colleagues who struggle with saying to their patient who's waiting for a hip replacement, waiting for a knee replacement, waiting for a cataract, and their quality of life is being impacted, that now they're not just going to wait the weeks or the months, but they're going to wait years. And we know that patients are getting sicker. We know that there is a mental health deterioration when your physical health is impacted. We know the caregiver burden and the relationship stress and the job loss and the general decline of a person's well-being. And so the numbers are impressive and difficult to wrap your head around. But as a physician speaking with one patient who needs their care and currently not having a way for that patient to have their elective procedure done because it's been canceled, because it's been postponed, then Ontario's doctors have been recommending ambulatory clinics that adhere to certain principles, integrated with hospitals, regional planning with a health human resource strategy, and all the while, not a two-tier system. Every medically necessary procedure is OHIP covered. No one jumps the queue. There may be an opportunity to buy a cataract lens. However, the OHIP lens in a cataract situation is a good lens, and the care wrapped around that cataract surgery for that patient who's first in line and chooses their entire service to be funded by OHIP would then proceed as the next patient to be seen. That's the integration piece. That's the human health resource strategy piece. We have specific solutions in our prescription for Ontario to talk about the doctor shortage, and we can go there. Licensing internationally trained physicians that are even currently here in Ontario. Long term, we need an investment here, more trainee spots, even collecting data as to where we need the healthcare providers, where the doctors and nurses need to be situated around Ontario. All of this plays in. But this announcement, this model of elective surgeries being offloaded from hospital ORs, integrated with the hospital all the while, is and can be a better model of care delivery for patients that right now are not getting the best care that they need and deserve.
All right, let's talk about the wait list. The goal of this plan is to reduce that wait list, which sits right now at about 206,000 patients, and return it to pre-pandemic levels by March. They think they can get about 6,000 surgeries done by March. What can we expect in the long run in regards to cutting this wait list down?
Well, I mean, as long as you expand capacity, so do more surgeries and more diagnostic tests, the wait lists are going to come down, except for some things like, you know, some diagnostic tests where no matter how much you supply, the demand keeps going up, they find. And so there's, you know, some controls that need to be done around appropriate requisitioning of tests among physicians and things like that, and some work has been done on that. But bottom line is, it's a demand and supply issue. You increase the supply, the wait list goes down. The question that we have here is, why are we not using the capacity we have in the public system? Why has this government made a choice to hand it over to for-profit clinics? And in real terms, what are the dangers of those? We've called every private clinic in the country, every private clinic in Ontario. We've posed as patients. We've said, you know, oh, I want to pay to buy my way to the front of the queue. Can I do that? We've caught the majority of them every single time selling two-tier healthcare. The idea that you would be able to, in some mythical world, hand over the ownership and control of public hospitals to private for-profit entities and then maintain single-tier Medicare, not true. It just, the evidence does not support that. And we already have, I mean, we'll be holding press conferences over the next week with a whole range of patients who are already in the tiny number of private clinics that we have in Ontario are being told, you either wait, you know, 2 years, they can make it up, right? The patient can't actually test whether this is true. This is a physician referring to their own private clinic. They're saying, oh, you can wait to get, you know, 6 months or a year to get your cataract surgery in the hospital, Or if you pay $2,000, you can have it in my private clinic 2 weeks from now. Patient does not know what the actual wait lists are. They don't know if that's total nonsense. Right. Sometimes it is. And then, has a choice. Do I have $2,000? I'm an elderly person, many of them on fixed income. What do I go without in order to pay for this surgery? And that physician, by the way, is billing OHIP. They're billing OHIP, they're extra billing the patient, they're upselling medically unnecessary diagnostic tests, saying that they need routinely, that they need extra eye measurement tests for $200, which they do not need. The OHIP covered test does the job, does it perfectly well. It's not even an issue of Cadillac versus not. These eye measurement tests by the experts do not show any additional medical efficacy. Informed consent would say that that physician has to tell the patient that they do not show any added medical value. But here, will you pay me $200 for the test? That just, it doesn't happen. There's no way to police it. The patients would have to complain. The government would have to set up a whole policing regime to police it. Then they'd have to enforce. Have we done that in long-term care? No, not even after 5,000 people have died in long-term care in Ontario are we doing that. No fines, no enforcement, no license revocation, no accountability. Why would we now privatize our hospitals?
Can I answer your question, your rhetorical question, which is, I can't speak to the question of whether doctors are ripping off patients by misleading them. I'll defer to Rose on that, and whether doctors are being ethical or not, and whether there's our way or the College of Physicians and Surgeons. But to your question, why are we doing this? Because doctors and hospitals are asking for it. That's what you haven't really answered. Is that the major hospitals, Sunnybrook, UHN, they're all saying, yes, let's do this. And you're making it sound like they're cannibalizing the hospitals. Why would they cannibalize themselves?
And Natalie, a point that I would want to make as well, and it's just really important, there are regulatory ways to deal with, and if indeed there are physicians who are tying a medically necessary service to the willingness of a patient to pay extra, those cases then need to come to light, because Ontario's doctors are very clear. Access needs to be protected, and in the system, when there is an opportunity to buy an additional, even, for example, when you're admitted to hospital, you can pay for a private room, or OHIP covers your bed and the aspects of your care that are necessary. You may need to share a room, but that's a decision and a choice that a patient can make. But if at any time a medically necessary procedure is tied to a pay out of a pocket, then yes, we are here to work with government to implement the model that's being proposed to protect against that happening, because that's not equal access. And so I stress the implementation committee that now needs to be struck after the announcement of such a model, and that Ontario's doctors and all external key stakeholders would be there to assure adherence to that integration with the hospital, the human health resource strategy, and the protection of the patient, that everyone has equal access to high quality, safe patient care, funded publicly by OHIP.
All right, we have only 1 minute left and a few questions that I want to get to, but we're going to end on this. Martin, Ontario isn't the first to expand surgeries into private facilities. We've seen this in Alberta, Saskatchewan, you've named them as well. How is it working for them, and what is it that Ontario can learn from that?
Mixed results. You didn't mention BC. BC has tried it, and Quebec has tried it. BC tried it under a Liberal government. Now under an NDP government, they're retrenching, but not eliminating it. And the fact that BC doesn't like it, it may not work well on Vancouver Island, it may work better in Windsor, who knows, means that you can actually roll this back at some point. That's the thing about having 13 different provinces and territories. You can actually innovate. I see that Prime Minister Trudeau called this an innovation, and he said, doesn't seem to violate the Canada Health Act. So it isn't extra billing, it isn't two-tier medicine, it's an experiment. Does it work? We'll see. But let's see if the government and the doctors and the nurses and the regulators can make it work, because it does require supervision, and the government could have buttressed it with a more rigorous and robust oversight mechanism.
All right, I know my producers may not appreciate this, but I'm gonna have to get your response on this as well.
Yeah.
You know, you've been talking about healthcare for over 3 decades, and when we use the word innovation, is this When we talk about innovation, is this what we're talking about?
This is just privatization. Call it, put all the fancy bells and whistles on it, whatever. It's just privatizing the public hospital system. Is it a good idea? Have we not tested it? Well, we've done it for 20 years in other provinces, more than 20 years in other provinces. Governments have pushed it and have had to retrench at various times. At the moment, the federal government, which is saying that this is innovation, is not actually enforcing the Canada Health Act in those provinces in any way. Shame on them. And so, we have in Saskatchewan, I just got contacted, a farmer has to wait 2 years for a hip replacement in the public hospital, or can pay $50,000 for the day surgery in a Calgary private clinic. He's going to have to pay to get his surgery, doesn't want to do it, thinks it's disgusting. He now is looking for help for that money. That's what the retired people who need health care have to look forward to after paying into our public system their whole lives. There is no question in my mind. We're not making this up. We have surveys of hundreds of patients. I'd be happy to share them with you to show you exactly how this is working on the ground now. Why would we expand it? It does, without question, pose an existential threat to public Medicare. The argument that you can do this and control the private clinics, not proven, not over 20 years across this country, doesn't work in long-term care, doesn't work in the other sectors we've privatized. It's just a bad idea, and we're going to have to fight it in order to protect our health system.
All right, we're going to have to leave it there. But Natalie,
thank you.
Rose, Martin, thank you so much. Very passionate conversation, very important conversation. Thank you so much for joining us on the program.
Thanks, Dan.
Thank you.
Thank you.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.